Hello everyone, how are you? Welcome to the second class of mine. So today I'll be covering the renal calculus disease and mainly we'll talk about urolithiasis in general, and I'll talk about kidney stones and ureteric stones. Bladder stones is a separate topic. When I'll cover bladder pathologies, then I'll cover bladder stones as well because the management is all different for bladder stones. Okay, so hi Vijaya, good evening. Just give me a quick confirmation. Am I audible well? The voice is clear, right? Hi, good evening, Ashleshwar. So, a warm good evening to all of you. Not a warm, I would say it's pretty cold outside, and January is just about to get over. And so, I hope that the incoming days, the cold will gradually decrease. So, today's topic is pretty easy. I think a bread and butter topic for all of you. It's renal calculus disease, right? And renal calculus disease, you see day in and day out in your reporting rooms during your residency and in general in your life. Frankly, one of the most important diseases that you will see in real life because of the frequency that it comes in the OPDs. So in this, we'll basically talk about the different types of stone, their imaging modalities in the form of ultrasound, IVP, and NCCT, and how the different types of stones can be differentiated on dual energy CT, and what are the latest AUA guidelines with respect to management of different renal stones, because I also want you guys to know what you are reporting, how is it beneficial for the urologist who is operating. And it's very important for us to mention some key pointers in a report which will help the urologist plan an effective treatment. Right, so let's just start. So we know that renal stone disease is a very common pathology that you see day in and day out. And recently we have seen that the incidence has gradually increased even in the younger patients. So when I sit in my OPD doing ultrasound, so even patients in the age of 25 to 26, they have renal stone disease, mainly because, of the water that we consume. It is high in calcium, so that gets precipitated in our kidneys. So lately, even in younger patients, the incidence has increased. And secondly, the disease is very important because it has high recurrence rate. So even if patients who have undergone PCNL, they have some residual stones or even recurrent stones, because it is actually a medical disease now, not a surgical disease per se. Now, if we look at the composition, so the most common composition is calcium-based stones. Now, calcium-based stones mainly compose of predominantly calcium oxalate. So, predominantly stones that you'll see in your OPD are calcium oxalate stones. They are the most frequent types, followed by calcium phosphate. Now, after that comes our uric acid and struvite stones. Now, the ratio, the percentage varies from different paper to different paper, but on an average, we can consider a 10% incidence of both uric acid and struvite stones. And the other kind of stones like, cysteine stones, xanthine stones, and other medication-induced stones like triamterene and indinavir stones, these constitute less than 1% of the stones. So bread and butter of our clinical practice is to differentiate between uric acid versus non-uric acid stones. Correct? And predominantly non-uric acid stones will see in the OPD and mainly calcium oxalate. Remember this important point. Okay. Now, the etiology of stone formation is multifactorial, obviously. So, calcium stones predominantly are seen in those patients who have a low urine volume. So, dehydrating the patients in dehydration, or even, residents. That's why the incidence is increasing in the younger population. We hardly drink any water during our day. Such busy is our residency. एंड लोग बोलते हैं कि रेडियोलॉजी रेजिडेंसी तो बहुत चिल होती है यार रेजिडेंसी चिल नहीं होती frankly this was the biggest misconception that was given to me during my radiology when I chose radiology रेजिडेंसी तो टफ ही होती है and so during the day we hardly drink any water and low urine volume is itself a parameter which predisposes to calcium stones. Now again, hypercalcemia, hypercalciuria, increase intake of oxalate or uric acid secretion in the urine, these also predispose to calcium stones. So there is a misconception that if there is uricospuria or hyperuricemia, then the stones formed are predominantly uric acid stones. No, even if there is hyperuricemia, that predisposes to calcium stones. Why? Because uric acid acts as a nidus, and this over this nidus, you get this calcium oxalate and calcium phosphate deposition. So even in hyperuricemia, the most common types of stones are calcium stones only. Okay. Now, decreased excretion of citrate also predisposes to calcium stones. So citrate is a protective agent against against stone formation. So decrease citrate excretion, increase calcium stones. For rest of the things like increased excretion of calcium, oxalate, uric acid, you have increased formation of calcium stones. Okay. Now, for uric acid calculi, the most important predictor is a low urinary pH. Okay? Most of the people think that hyperuricemia, hyperuricosuria will predispose to uric acid stone. No, low urine pH predisposes to uric acid calculi. And hence, in the later slides, we'll talk about that the management of uric acid stones is predominantly medical. Okay, you increase the urine pH. It is known as alkalization of urine. Okay, a very, very important pointer to know that uric acid stones are precipitated by low urine pH. Now, struvite stones, we know from our PG preparation that UTI with urease positive organism is a risk factor for struvite stones. And again, cysteine stone, cystinuria is a risk factor. So the spelling of cystinuria is wrong. So you cut off the E. Take a cystinuria, cysteine stone formation. Now let's quickly see the clinical presentation. So we know that predominantly most of the times it is an asymptomatic presentation. It is incidentally detected when the patient comes to you with a non-specific type of pain. However, in some cases, a typical renal colic or a ureteric colic type of pain can also be seen. Now, most common site of obstruction of a renal calculi or a ureteric calculi for that matter is a upper ureter at the ureteropelvic junction, or it can occur at the distal ureter at the vesico-ureteric junction. And the third point of ureteric narrowing is the place where it crosses the iliac vessels. Now we discussed this part when we discussed the first class on a radiological anatomy and imaging techniques of urinary system. So all of you who have attended the class would know what I'm talking about, right? Now, depending upon the site of obstruction of this calculi, the referred pain can be either in the iliac fossa. So if it is a mid-ureteric stone, the referred pain will be in the iliac fossa. But if it is a distal ureteric stone, then the referred pain will be in the groin. I think we know this from our anatomy and our PG preparation times as well. Now, specifically, lower ureteric stones have some bladder symptoms associated with them as well, like increased frequency, urgency, and suprapubic pain, mainly because they're closer to the urinary bladder. Now, whenever there is increased pain sensation, intense pain, there is always associated nausea and vomiting. And sometimes a recurrent long-standing stone can erode the walls and can lead to hematuria. Now, since there is stasis of urine, so secondary UTI is also one of the symptoms of a long-standing urinary obstruction secondary to a stone. So, this is briefly about the clinical presentation of renal calculi. Now, let's look at the overview of imaging, how we image a renal suspected urolithiasis. So we know that NCCT is the gold standard and the investigation of choice both. There should be no doubt regarding this, correct? We all know this. NCCT is the investigation of choice whenever we are suspecting a renal or a urolithiasis. Now, according to AUA guidelines, so American Association of Urology guidelines, the first line of imaging modality in any suspected cases of urolithiasis is always an NCCT. Okay? Now, you will say something that, sir, in our PG preparation times, we learned that ultrasound is the first line of imaging. But AUA says that NCCT is the first imaging modality when you're suspecting a renal colic. For example, patient came with a typical pain in the line radiating to the groin, or a groin pain, and you suspect it is type of a colicky pain. So you're suspecting a renal or a ureteric colic. You have to order a NCCT first. Now, I agree that in emergency scenarios, sometimes, there is a non-specific type of pain. So let's say patient came to you with an epigastric pain or a diffuse pain or a pain specifically looking like an appendicitis pain, then obviously the first investigation in that case will be an ultrasound. However, if the clinician or you in the or you as a radiologist suspect that this type of pain is looking like a renal pain, according to AUI guidelines, the first line of imaging modality is a non-contrast CT. However, the European Association of Urology recommends the first line as an ultrasound. Okay, so remember these two important points. These are the official guidelines of AUA and EUA.